Good evening, everyone. My name is Alyssa Scarciati. I'm the Clinical Education Manager here with Leixir Dental Laboratory Group. We appreciate you spending your night with us. We are presenting session 2 of our program with our partners over at Zest. It's Rethinking Edentulism. It's a 3-part webinar series, so we will be covering, like I mentioned, session 2, presented by Todd Hydock, Karen Gauthier, and Amy Halile.
Hi, everyone.
I'll get to the introductions. You can go to the next slide. There we go. Okay, awesome. So a couple just little housekeeping items. We love having your interaction. Session 1 had a lot of great questions. So, please feel free to enter your questions. They'll actually go on the comments section. So I see a couple of people saying hello, and welcome. But if you guys have questions throughout, we're happy to pause throughout the presentation and answer those. So just to go over our agenda. So we are going to be starting off with a full arch overview, and then we'll be exploring new fixed options. We'll be reviewing case selections. We'll go over some clinical cases. We'll review clinical and laboratory workflows, and then we will go over education.
It's got a delay.
Perfect. Okay. So I do just want to introduce our team that is presenting tonight. We have Amy Halile. She is the director, she is the global education manager with Zest. Amy presented on session 1.
Hi, everybody.
And then we have Leixir's very own Karen Gauthier. She is our surgical advocate here at the lab. She's a great resource and does provide chairside support in office. So she'll be chiming in and, just answering any questions that are specific to the lab side of things.
Hi, everyone. Thanks for joining us.
And then we have Todd Hydock. So Todd is the Director of Business Development for Laboratories with Leixir. Has a lot of experience with Zest and on the lab side as well. So he'll be doing our presentation this evening.
Hi, everyone.
I guess without further ado, I'll let you take over. Thanks, Todd.
Yeah, let's get going. Great. Well, welcome, everybody. Good evening. Thanks for taking time away from your practices and your families to join us this evening to go over exploring new advancements in fixed full arch dentistry. And I just pretty much want to pick up from where Amy left off. So if you had the opportunity to see our first session of our 3-part series, Amy really went over about the various ways that you can utilize locator abutment for removable applications. She gave a little teaser at the end about locator fixed. And so I just kind of want to start from pretty much where she left off. And, when she originally went over locators, she talked about all the various options that are out there, whether you want to use locator for root, locator on our dental implant, as well as other dental implants. And when you look at locator in general and the way it works in terms of the platform, we're going to get more into the fixed options and the fixed solutions as it relates to locator. And the one thing I do want to point out is a lot of the questions that I think that we got the last time were about angulation. And one of the things that we started introducing as early as last year was the new angled locator. And this is going to play a big role in your decision making when you're treatment planning cases, especially when you're looking at locator fixed and angling your implants. And so I'm going to incorporate that as well in this evening's presentation. And when you think about locator fixed and what the solution is the great thing about it is that it's on the traditional locator that everybody is very familiar with. So whether you're planning a case on whatever dental implant of choice that you like to use that accepts a genuine Zest locator, as well as a locator implant, a locator that goes on top of an MUA, and now with our newest addition in our portfolio, angled locator, you can build and restore your cases not only for removable but also for fixed on any type of traditional locator that you see here. The one thing that Amy pointed out last time, but I just want to reiterate because it is very important, is when we're talking about fixed full arch restorations, the one thing that we're always competing with is restorative space. And so historically, when clinicians were angling implants, utilizing MUAs to correct the angulation and then stacking a locator MUA on top of it, it took up a fair amount of space. And so this is something that we've addressed, specifically with our locator angle. So it actually can reduce the amount of restorative space that's needed when you are working on these angles. When you're working with implants that are, straight up and down, there is not much angulation that's being there. You could just use a traditional straight locator and even gain more restorative space. So let's dive into locator fixed and what this option is and how it can be best used in your practice. And so a lot of clinicians out there, maybe on this call, be familiar with all the various options, obviously for the patient with removable as well as fixed. But what we've known in the past is fixed was always a screw retained full arch restoration. Fantastic option that's out there. One of the things that we found is that it's not always easily accessible to all patients due to cost. A lot of clinicians have actually veered away from offering screw retained fixed solutions, whether it's based on lack of education or comfortability of it, or maybe based on their perception on that these cases are really expensive and that patients might not want this. And when you look at the patient experience as it relates to starting from a denture and adopting implant therapy, you can see that the positive progression as you start incorporating dental implants, especially when you add more implants versus just two. And the one thing that we see here is that when a patient says yes to implant therapy, and a lot of times that they accept it and they want something that's fixed, and the doctor's agreeing with them as well and says that they should also have fixed, a lot of times they can't necessarily afford it. They go through financing, maybe their FICO score is a little lower than they expected it to be, so maybe they're not being able to get the $25,000, $30,000, $35,000 financing, and then maybe they're able to get something in the $16,000, $17,000, $18,000 range. And so a lot of clinicians, what they've had to do is make that decision on, well, it's not going to be hopefully all or nothing dentistry, but they usually revert to like a 4-implant locator removable case, which is a fantastic restoration as well. But if the patient was accepting implant therapy, especially for fixed restoration, the goal is how do we give that patient what they need and what they're asking for. And that's where locator fix comes into play. So locator fix is that sweet spot where what you'll find is that if you look at the treatment details at the bottom and look at the kind of the national average cost to these patients, whether it's from a denture to a 2-implant, a 4-implant locator removable, all the way to a screw retained, what you'll find is that based on what you currently charge in your practices for full arch screw retained and for a 4-implant locator removable, you'll find that locator fix primarily is going to fall somewhere right in between. That doesn't make it a lesser restoration option. It's a great fixed restoration. It actually makes it easier for clinicians to do, less chair time for the patient as well as the clinician, and it makes these cases more affordable for these patients that need the service. And so a lot of questions we get is, well, what's different about locator fixed? The questions I get a lot are, well, what's the new abutment? And the great thing about this is that it's the same traditional, genuine Zest locator abutment that everybody's familiar with and has been familiar with. The difference is that we created a new housing, and the housing is gold. It actually has some more retentive elements, and the internal aspect of that housing has the tolerances to accept the new inserts. And these new inserts are not your traditional inserts that you're familiar with locator removable, which are nylon. This is a proprietary material that's similar to like PEEK, but it's actually precision milled. So we mill these inserts in our CNC machines in Southern California. And the tolerances are so tight that it's not very forgiving. And that's what we want because we're looking for a rigid, stable, fixed restoration. And that's what makes this different than what you're familiar with traditional locator removable. The locator fixed Housings and inserts are synonymous in spacing with locator removable. So as you know, a lot of these treatments are done with 9 to 11 millimeters of prosthetic room. You can do the same thing with locator fixed in certain cases, where everything applies and you have the proper thickness of the restoration with that vertical space. A lot of times I'm seeing anywhere from 12 millimeters or more. The clinicians are still giving themselves some room for locator fix, but in cases where we don't really have to angle implant stack any type of components, we don't have to do as severe of an alveoloplasty to create the restorative space that's needed for these locator fix cases. And where this really comes into play is if you have a patient that has a current locator removable prosthesis, but you would like to put them into fixed, if you have the proper restorative space, you should be able to actually convert that patient from removable to fixed on the same locator abutments that are in their mouth. So what does this look like in comparison with locator removable and locator fixed? Now, as you can see, the abutments, as I mentioned, are still the same. Your processing insert, the black processing insert that you're all familiar with, it's the same processing insert that's going to be embedded into the housing, but the housings are different. As you can see, this traditional silver locator removable housing, and then you have the gold locator fixed housing, as I described in the previous slide. And then what you have here is the inserts. So the inserts are what makes it different along with the housing. And it's obviously with the appliance design, instead of having something that is tissue borne and you're relying on all the unchanged landmarks, you're having something that's more of a hybrid, cleansable design for locator fixed. So with locator fixed, there are a couple different colors for the inserts. These colors are not specifically in terms of like poundage or the pull-out strength that you're familiar with locator removable. This is really based on the tolerance on how the prosthesis is inserted and how it's removed. So I call them micro tolerances. The other thing on the right side of the slide here is that this is the armamentarium that's needed for locator fixed. We'll get into this in a little bit more detail, but what we have is a handle that acts as almost like a kind of like crown remover, kind of a reverse action handle, and it has a couple different tips to it. This tip that you see here is it applies to help insert the prosthesis, which is very simple to do. This braided wire lasso helps with actually removing the prosthesis when the patient comes in for hygiene visits. And both of these screw onto the top of the handle here. The other enhancement that we have done is that we created a new locator core tool. So for a lot of you that are familiar with the old core tool, sometimes it will remove an insert. Sometimes it gives you a little bit more difficulty doing that. This core tool actually expands open, and you're going to need that for the more rigid locator fixed inserts to be able to remove that. So we created a more ergonomic, doctor clinician friendly core tool that can be used not only for locator fixed, but can also be used for locator removable. So getting back to the inserts, so I mentioned that there are multiple different colors, and so I wanted to explain the differences and how they would be used clinically. So for a 4-implant locator fixed case, this is the minimum amount of implants that we need for locator fix to work. We need 4 implants, cross-arch stabilization. And so when you're working on a case like this, you're going to use the green inserts. These green inserts are the most rigid of the 3. When you're doing a case that's more than 4, so you're on a 5 or 6 unit case, you're going to use a combination of the tans and the blues. Rule of thumb is that the tans are always in the anterior, posterior of the arch, and the blues are going to be in the mid-arch. And so one of the questions they get is like, well, why don't I just do all 5 or all 6 with the greens? And as I mentioned before, it's like the tolerances are very, very tight, but there's a micro tolerance difference. So the best way I can always explain it is if you had the same exact patient, 2 of them, and I blindfolded you and it allows you to insert and remove a 4 implant locator case with the green and a 6 implant case with the tan and the blue. It would feel the same way, to insert as well as to remove the prosthesis without any issue or without any hassle. And that was the goal of this, is to make it to where, regardless of how many implants that you're doing, your experience of inserting and removing the prosthesis is going to be the same. The other thing I want to point out is that uh, when we're doing like a screw retain full arch case, rule of thumb is that you can go 1.5 times the AP spread. Most hybrid cases are designed with a first molar occlusion. With locator fixed, the design is a 1-to-1 ratio. So whatever your AP spread is, you're going to be able to go 1 times that as beyond those implants as part of your distal extension. If you have a patient who historically has broken uh, dental devices in their mouth over time and they have heavy parafunctional habits, you may want to consider going 0.5 times the AP spread and shorten it up that cantilever. So what would this mean if you're working on a case and your laboratory technician tells you that you prescribe locator fixed and your cantilever that you're prescribing is way longer than what the 1-to-1 ratio is? Well, then you have to make that decision with your laboratory technician to go probably to screw retain for that case, and that's totally okay. Locator fixed was actually brought to the market as an additional solution out there for doctors, laboratories, and for the patients. So there are going to be some cases where you and your laboratory technician decide that you might need to go to screw retain versus locator fixed. But I think you'll find that a lot of times the 1-to-1 ratio is going to be just fine for your cases. So I want to just go back to the core tool. This core tool, I feel, has been a game changer for a lot of clinicians, not only for locator fixed, but also removable. So as I mentioned before, it's like the removable collet is very similar to the old design. The only difference is that it actually has some openings around the collet. So when it's screwing onto this removal end, this actually acts as an obturator. So it actually will expand the collet at the end. And so when you put this into your insert, whether it's locator removable or locator fixed, and you turn the handle, it'll expand open and just allows you to easily peel out the insert. So this is a game changer for whether it's you that are doing this or your staff that's doing this. It happens. It comes out really quickly, and then once you unturn it, the insert just comes off. Now, when you flip this apparatus around, now you have the insertion end. It has this little gasket on it, and this actually will allow you to pick up any insert without having to hold it with your fingers like uh, the old core tool design. And so this just makes it easy to pick it out of the packet or in your box that you keep your locator componentry in, and you just insert that into the prosthesis. And then the handle is more for ergonomic purposes, because when you're using the insertion end with a locator insert, you're going to have to apply a fair amount of pressure to really get it to insert into that housing because the tolerances are so tight.
Todd, we just had a question. Can you do this for a chair side pickup?
So great question. Yes, and I have some cases that I'll show. What we found is that so many clinicians are so used to picking up dentures for locator removable, and the clinicians that like to want to go through currently right now like a totally digital workflow, they end up with a restoration with the recesses already kind of built into it, regardless of the type of material. So it could be zirconia, it could be metal reinforced, and the clinicians are actually picking these up in the mouth and having great success with it. And they really like that technique. The clinicians that don't want to do that type of technique, they don't need to. They can still take other type of records and have like verification and working models at the laboratory and have the laboratory process everything for them. But that's a great question. So some quick case requirements. I mentioned about 4 implants. You still need your same, osseointegration of your implants, or at least a minimum of 35 Newton centimeters if you're going to do immediate load application. The implants need to stay within 20 degrees. So the nice thing about locator fix is that even if you're using straight abutment, you could still go to 20 degrees with these inserts. And then I mentioned about the one-to-one cantilever. Everything else that applies to fixed full arch therapy applies to locator fix. Nothing's different. So the teeth need to go where the teeth need to go. Your implants are placed where, obviously where the bone is, and you correct the angles where needed. And the number one thing is, really being cognizant of your restorative space. But as it relates to the dental implants themselves, nothing changes, as well as your material choice. You're choosing materials based off of what the patient's needs are and what's happening with the opposing. Sometimes it's based on cost. All that applies to locator fix as well. So I mentioned about AP spread. This is really important. We have a restorative laboratory prosthetic guide that we can send out to everybody, and this was taken from that. But it's really, really important to understand where your implants are placed, what you're dealing with, and what your AP spread is, because to have the best successful cases overall, even with screw retain, most screw retain cases that have breakage is usually those terminal implants, and a lot of times it has to do with a pretty large cantilever. So with a one-to-one cantilever, you stay within those confines, you'll be fine. So it's really important in terms of where your implants are placed, and also in terms of the symmetry and the distribution of your implants, which really is not much different than we would apply these to screw retain restorations. As it applies to the different types of materials, as I mentioned before, you can choose whatever material you want. The key aspect of this, though, is regardless of the material that you choose, we always have to be mindful of is what is the required thickness of said material around these housings. No different if you're doing a tie base and a screw retain restoration, you still need to be mindful of the amount of material that's around those tie bases to mitigate any breakage or fracturing of the prosthesis. So what are some of the other advantages of using locator fixed versus something like screw retained? And as you can see here, when we have screw retained cases, we're dealing with access holes. And when you're dealing with locator fixed, there is no access holes. Everything is completely solid. So that helps in a number of different ways. One is the amount of time that you're saving from having to retrieve all the screws and then put them back and put everything back together and close up those holes. The other thing is based on what we end up with if we're doing, say, a conversion, whether it's immediate load or delayed conversion of a denture. A lot of times we'll see this. This is quite normal for screw retain cases. We have to cut the cantilever pretty short, and even though we have some thickness here in this restoration, still things like this happen because there is no support. This is not abnormal. Not saying there's anything wrong with this. It's just part of doing screw retain cases. But when you're dealing with locator fixed, we don't have those access holes going through the prosthesis. And so we're able to kind of keep the integrity of the prosthesis, but also too, is we still have to be mindful of how much space and how much thickness that we have around those housings of the locator abutment. And then there's a number of clinicians that we work with that like to do conversions. So whether it's immediate or delayed conversions of a denture. And as you can see, in terms of the amount of time when you compare a traditional screw retained case that was converted from a denture, chairside, and a locator fixed case being converted chairside, you'll see it's a third of the time that it takes to do this conversion. So let's jump into a couple cases here. So this is what I see a lot of clinicians start adopting a locator fix. They have these patients that they have a removable prosthesis, but they would like to go fixed. And so a number of things that can be done is we can take the patient's existing locator um, overdenture and we can convert that into fixed. But a lot of clinicians are liking to keep that as a backup and make a reference denture. So in this case here, you'll see that the clinician is using made a reference denture. They're making sure that they have the proper spacing to do the pickup. We're going to put all of the housings in the mouth on top of the abutments, and then we're going to do our pickup. And as you can see, all of these were picked up just like traditional locator removable. Nothing's different here. The only thing that changes is the next step is that we're just going to remove all of the flanges. We're going to make sure that intaglio surface is, if we can get it ovate or at least flat to make it cleansable, that's what we're trying to achieve here. And then we can snap it back into the patient's mouth with the final locator fixed inserts. And now the patient has a fixed restoration. Now, keep in mind, there is no reinforcement in this prosthesis. This is normally kind of setting the stage, putting the patient into a provisional so we can make sure that we can work out any of the things that need to be worked out. Maybe the patient doesn't like the size of the teeth or the shade of the teeth. Maybe at some point they realize that they rather take their teeth out to clean versus having it fixated in their mouth. So there's a number of reasons why we would do a conversion like this, get the patient in their training wheels, have discussions with the dental laboratory, and choose the appropriate final restorative material for their final prosthesis. Here's another case with, this is with Dr. Saab. It's a 6-unit case. And so this case here is great because this patient actually has a wonderful locator removable prosthesis. It's got metal mesh reinforcement, great distribution in terms of the dental implants. Everything's fine with this case. We have, it's pretty much palateless, and the patient always wanted to have fixed, couldn't afford it. So what Dr. Saab, when we introduced locator fix clinically to early adopters in 2021, he gave this gentleman an opportunity to do the conversion to give him fixed restoration. The one thing that Dr. Saab did not want to do is he did not want to touch this beautiful removable prosthesis that he had. So what he did is he decided to make a reference denture. He put on the locator fixed housings. He sandblasted everything. And then he made sure that he has no undercuts, blocked everything out, and just did a traditional pickup like most clinicians know and do on a regular basis. He then, as you can see here, these are all of the locator fixed housings with the same black processing insert that you're familiar with, the locator removable. So this allowed him to cut everything back, protect the housings, and then able to try this in and out to make sure that he's got the proper material and he's got the proper occlusion and he's spot on to where he started from. Then he removes those black inserts and places, and this is a 6-unit case, so he's going to use the tan, blue, tan technique. And now we can put this gentleman into a fixed restoration. Now, mind you, this was a reference denture, so there's no reinforcement there. So once again, this is giving this gentleman kind of like the training wheels of a fixed restoration so we can kind of work out anything that might need to be changed, and then also decide on what type of material that we're going to use for the final restoration.
Todd,
You see some,
a couple of
yeah,
questions that came in.
yeah, okay. What do we got?
So, we have, how can you remove the denture with these locators if the denture still has all the flanges? Am I reading that correctly?
So yeah, so how can you remove the denture with these? Okay, so great question. So I'm not sure if you missed something, but when we do the pickup of a denture, and then what we're going to do is we're going to cut all the flanges back. So locator fix, once it's in the mouth with the final inserts in, it stays in until you use the tool to remove it. So by the time we get to that point, we're already removing all the flanges. So we're not using this as a fixed restoration with all the extended flanges of a denture. We're cutting that apart. So like if I go back here, you can see we started with this and we just did a traditional pickup, just like we do a regular locator, and snaps in and out. And why is because of those black inserts. And so once we did the pickup and we're good to go, now everything, all of this is actually this. So everything got cut back and made it into a more hybrid design cleansable restoration. So this is what, with the tools that I'll show you, allows us to then remove the prosthesis. And that's a great question. Just gonna let everybody know, like, as you decide to adopt this option in your practice, you wanna make sure that you're crystal clear with your dental laboratory, that your laboratory knows how to do these types of cases. And so not all labs are doing this properly. And what I mean by that is the clinicians are sending a script saying, I'm doing a locator fixed removable prosthesis, or they'll say fixed overdenture. And sometimes that, they're not familiar with locator fixed, and you send them all the parts and pieces, and they're sending you back something that kind of looks like in between this and this, because they're thinking overdenture, but you're saying fixed, and it's locator, and they're very familiar with locator being removable. So one of the things that's important as you're working with your labs is you need to have these discussions with them, but then also talk with your Zest reps. We have a number of clinical support team. We have account managers out there that are supporting everybody that can also give you the guidance and chairside support that you need.
Thanks. So they actually clarified. They said, I was asking not this case, the case before when AI flags was still there.
This one?
Yes.
So this is almost the same type of case. So they just have a denture, and then as you can see, everything is kind of removed. So all the flanges were removed. This is kind of just a step-by-step, but as you can see, there are no more flanges left here. So we'll show a case too that actually shows all the tools and a video of how this actually gets removed.
Okay, another question was, do we need more metal bar to reinforce the denture base for locator fixed?
So I would treat locator fixed as with your final restorations, just like you would screw retained. So meaning that if you're deciding to use a metal reinforcement, whether it's embedded into digital teeth or wrapped in acrylic, you're still going to want that same thickness that you normally would with locator. With just traditional screw retained. You can use all zirconia. You can use zirconia that's embedded with metal reinforcement. Pretty much the sky's the limit of material choices that you want to use. Just keep in mind is that you're not necessarily going to use a denture that's got a mesh reinforcement and pick that up in the mouth and then say that's going to be your final restoration, because it's just metal mesh. That something's going to probably give at some point. It depends on the patient. If you have an 80-year-old female patient that you're doing a mandibular case and she's got an upper denture, that's a clinical decision that you need to make and say that might be her final restoration with just metal mesh. But I don't think anybody would really put metal mesh into a screw retained definitive fixed hybrid restoration. It just wouldn't be enough.
So treating it like a traditional fixed hybrid.
Correct. Yeah. So all the fundamentals of fixed full arch, screw retain, really all apply to locator fix as well. It's just you just have that versatility of the ease of use of this. You still have to be mindful of the materials and the thickness of the materials, and where your implants are placed and how they're spaced out. Wait, do we have some more questions? I see.
A couple more, yes. Even after flange reduction, there are concavities. How is hygiene maintained on a day-to-day basis? Yeah,
so some of these cases that you see, like if you're looking at these specific pictures, there may look like there's some concavity. Our goal, as from a clinical standpoint as well as a technical standpoint, is to make these intaglio surface of these prostheses like ovate, or if you can't get them as ovate, you can make them flat. And the goal is and that's kind of like on the lower, it's not as difficult. On the maxillary cases, we have to be mindful of having the just amount of space where we have like intimate contact with the soft tissue, but it's cleansable, but we're also being mindful of the phonetics. And so it's kind of like it's a very fine dance that you're going to play, with your laboratory to make sure you have that dialed in. And that's why the provisionals play such a big role in what I just showed you there, especially in the maxillary case. mandibular case, we have a lot of flexibility. Not everybody wants an old school high water design, but we do we do have more flexibility of that space. And I stole this from Dr. Saab at one of our masterships. He had said that like whether your lab is designing something or you're converting and you're shaping the integular surface of your prosthesis, if you take a piece of floss and run it from the face of the teeth around the integular surface to the lingual or palatal of your prosthesis, if that piece of floss is not touching all aspects of the undersurface of the prosthesis, that's where it's going to be a trap. And if you run that along the arch, you're going to be able, it helps you be more mindful of where are those areas of interest that you want to kind of recontour, redesign, or add material. So these are things that are in the hands of clinicians, but also as you're working with your laboratory as well.
Okay, and then just one additional question related to that. Secondly, this becomes an entirely implant supported and retained. Will 4 implants be enough for the support?
For a mandibular case, I would say yes, especially if you have a good AP spread on that. Maxillary, I've seen a number of all-on-4 screw retained that have been very successful. I've seen a number all-on-4 locator fixed be successful. I think clinically and historically, it's always great to see 6 implants in the maxilla. This is going to be an implant-borne or abutment-borne prosthesis, no different than if it was screw retained. So it's a little bit different than when we're talking about like locator removable, to where it's a tissue-borne prosthesis. And I know even if you have 4 implants, we can argue and say, well, it's still kind of now abutment-borne because it's not just 2 and we have all that flexibility of the rest of the prosthesis on the soft tissue. But at the same time, the nylon inserts for locator removable, there's a reason why they're still nylon. So there's a lot of other like knockoff type of abutment, products that are out there, and then they tout that, oh well, our inserts are more rigid. You don't want rigid inserts for removable. You want something that has the resiliency and allows for that dynamic with the soft tissue. So which is why like those more rigid type of materials like what we use for locator fixed, there's a reason for it, because it is implant abutment borne prosthesis.
Okay, right. And then one last one, and then we'll let you move on. I mean, we can revisit some questions at the end. Would you place with a slightly longer cuff for the abutment to give the lab space to add more intaglio surface?
I would say sometimes you might be splitting hairs, and I'll go through this in the step-by-step. We're still going to choose our locator height just like we traditionally do. So it's going to be, if we look at, say, a patient like this, we're still going to take off the healing abutment. We're still going to measure the cuff height. Whoever asked this question is perfect. They must have known what my next slides were going to be. So we're still gonna measure the soft tissue from the abutment level to the highest point of the sulcus. So depending on the implant systems that you're using, some of the locators are either like whole numbers, so it's like a 2, 3, 4. Some are 2.5, 3.5, 4.5. So the rule of thumb is that if your highest, let's just say your sulcus point is 3 millimeters, you're going to use a 3 millimeter abutment. That's what you're going to choose. It's already built in where the rest of the locator is going to stand proud and be in the ideal space. If you're in a half spot, you're kind of close, always go up, to the next size, and you'll be fine. So to that question, though, is that you may want to discuss it with your laboratory, but it may be not necessarily ideal to go up a size just to give more space, because that could create potential issues too, maybe around that site, especially if we're dealing with like in the anterior segment and we're trying to get the phonetics just right. It may be actually better if you choose the ideal normal size and then do some gingivectomy or something and just tweak the soft tissue a little bit, and versus going to a larger height abutment. So with this, to keep in mind is like, we're kind of going old school now, where we're looking at if we're on a model, if we're in the mouth, looking at angulation and using the old angulation guide. In the past, this was important because we weren't choosing necessarily just the inserts, whether we need standard or extended range for removable, we're now looking at it as like, can we or can't we do locator fix depending on the angulation? As I mentioned before, locator fix can go up to 20 degrees, per site. Now we have locator angled, which is great. It changes the whole dynamic of the case as well. But you still want to be mindful of your angulation. Now, if you're scanning, if the laboratory is working on this digitally, we can see in the digital world what our true angulations are. In the mouth, I've seen thousands of cases. I still can't tell you if a case is 17 degrees or 23 degrees. I just can't do it with the naked eye. But with these different little devices, we can. So it's still you want to be mindful of where your angles are. So we're still torquing in the abutments just like normal. Keep in mind, we talked about this, is like there's a couple different options for you to change your angulation. You just want to be mindful of how much restorative space you have. And what we found is that the new locator angle, this comes in a 15-degree angle. That's it, one angle. And the question is, well, why only one angle? And this is because if you have 15 degree and then you have locator fix that can go 20, now we're going 35. Or if we're doing removable, same thing. We have a number of different, various types of inserts that we can change our angulation as well to build on top of that 15 degree. Plus, it actually keeps the restorative space low. So I want to jump into some different types of record taking. I don't know everybody who's on this call, but every time we talk to a group, whether it's on webinar or it's live in person, half the room is doing things analog and the other half is doing things digitally. And so want to kind of go over a couple of these different ways of doing this. Really should not change kind of what you're already currently doing in your practice. But when it comes to locator fixed, if we're going to do things from an analog version and we want to work with an actual verified working model where the laboratory is going to process the whole entire prosthesis for you, you can put on the locator, like these upside down like wine glasses, so the locator impression copings. You can actually jig them all together with some floss and jig gel, whatever material that you like that's got minimal shrinkage. And you can actually pick this up in an impression and send it to the laboratory. My recommendation is don't put the analogs in. And I would write on the script to your laboratory technician that you did create a jig. Your laboratory technician is not going to believe you. They're going to take some type of sharp thing and stick it in there, making sure that there's something rigid in there.
That's very true.
Just to do it, but and just to make sure we're on point. And so when you do this, you're going to have a great outcome. If that's the way you like to take your records, awesome. You could also still just take it like old school way and take your impressions that way. I'm a big fan. If you're going to do it this way, I would probably jig it together, especially when we're talking about locator fixed. Another option is out there is for your iOS. So we have a locator scan body. If you're not familiar with it, we brought it out back in like 2019, and so you can use the scan bodies. The technicians, if they're working off a working model and want to do something digitally from that point on, they can use this on a benchtop, or you can use your iOS and do your traditional scans. Another option of doing this as well is that you can actually take like an existing denture and do a PBS like an impression, with the denture on top of the locators. Then you're going to do your scan of the prosthesis of the bite, and then you can put in your scan bodies and take an impression of that. So there's a number of different ways that we can approach this, just from a digital platform way of doing things. The one thing I want to make, just kind of point out is that we're not a digital platform company. We just play in that space, and our goal is to continue to give solutions as we're kind of still kind of aligning with all these different workflows that are just driving the industry right now, which is fantastic. I mean, what a great time to be a dentist and as well as a dental technician. But the scan body, it was something that came out, like I said, in 2019. We're currently working on building our DME libraries. So in the future, in the near future, our locators will be on all the various connections through exocad and through 3Shape. We're working on currently right now a digital analog. So if you want to take, your impressions and digital impressions, send them to the lab, they can print a model, they can put the digital analog in there, and now they have a working model as well. So there's a number of different ways that we can skin this cat. It's just a matter of providing all of the different resources out to the community, and that's something that we're currently working on right now. Traditionally, a lot of clinicians like this for removable, even fixed, is receiving that prosthesis with all the recesses already in play, and you can prescribe to your laboratory that you want the undercuts put in there. If a vent hole is applicable, you can ask for that. But the goal is, how do I get my prosthesis and do my insertion directly chairside with minimal issues? And that's where your communication with your laboratory is going to be big, and communication not only in terms of verbally as well as written on your script, but then also your records are part of your communication as well to your laboratory. So there's a number of different ways to make these prostheses, whether you're doing something that's all zirconia, you're doing something that has a substructure embedded into the digital denture teeth. So the great thing is that this doesn't change the workflow for you clinically, and it doesn't really change the workflow for the laboratories. As you can see here, we have this is Trini or Trilor embedded into digital denture teeth, and so this can all be done fairly easy. This case here is the same patient, same type of prosthesis of that patient, but one's in all zirconia and one's the Trilor material embedded into crystal ultra teeth. So just kind of pointing out, it's it doesn't matter the material, it's just what makes the most sense for the patient, and being mindful of your spacing, your thickness of your material around your housings. So let's talk about how do we insert this. So when the prosthesis is finalized and the final inserts are put in, the clinician will actually just snap it in the mouth. So they'll feel and hear an audible click. We ask the patient to bite down on a tripod of cotton rolls, and majority of the time they're going to actually insert the prosthesis on their own. If they're just to double check to make sure it's fully seated, as I mentioned, we actually have that reverse action handle with the tip that's going to sit on the occlusal table over each of the implant sites or the abutment sites. And then we're going to hold that down at the top and click on it, and we start in the posterior, then the anterior, and just click it a couple times. You can't over insert it. And this just makes sure that everything is fully seated down. We're going to know we're totally down. We can see on x-ray in the spacing, but really you're going to tell because we've already adjusted the occlusion when we were trying it in. So the occlusion is either going to be on or it's going to be off. So here it's just giving you an idea. You can't hear the sound, but you can see it's not really traumatic to the patient. Doctor's holding the other end to make sure that the energy of this apparatus is guiding it directly to the prosthesis and the abutment, and just helping everything get seated down. And then here we have a patient where this is immediate load. So the patient went through surgery. The doctor picked the prosthesis up in the mouth, kind of cut everything back, put the final inserts in, and now he's just seating this in the gentleman's mouth. Now, the one thing he did not do is have him bite down on a tripod of cotton rolls. He felt like he got a real positive seat just inserting it himself. And then he's going to use the tool, and he's just going to hold the tool down, and he's just going to give it a couple clicks. So the patient's in no pain. You can see that his jaw's not really moving anywhere, so it's very atraumatic to the patient. It's just making a clicking sound. And it's just reinforcing to make sure that all the componentry is down all the way. So the one thing that I get a lot of questions on are the removal of this, because a lot of clinicians feel that this potentially looks a little barbaric, of this big wire coming out and clicking, and almost like feeling like it's going to, or sounding like it's going to pull the prosthesis, out of the patient's head. And it's actually the opposite. When you actually see a live patient come in for hygiene, either the assistant or the doctor, what they're going to do is they're going to loop this around the distal extension. They're going to pull on the handle to make that wire taut while supporting the prosthesis, and give it in a couple clicks. And all it's doing is disengaging the housing insert apparatus from the abutment. That's it. And once that happens, then you can work your way around the arch, and it takes about 10 seconds to remove. And as you can see, it was atraumatic to the patient. Her head wasn't moving, her jaw wasn't moving. It was like nothing was even happening to her. This is really, really important because this makes it for a great patient experience every time they come in. It makes for a great doctor experience when, say, if this patient was maybe not so compliant with their hygiene and you needed to see this patient more than once a year to remove it, maybe every 6 months, this would be an easy way to do this type of prosthesis that's out there.
Hey, Todd, I have a question.
Yep.
When, let's say you have that patient that you have to see more for hygiene, would you always change out the inserts at that appointment?
So great question. So the answer is yes. And the reason why is that these inserts do not wear. They don't wear on the abutments. They don't wear, within the housing. They're totally static. So there's no like real micro macro movement happening because we have 4, cross arch stabilization minimum. So there's nowhere for it to go. But when we remove it, it creates I'll call it like micro distortion. And so when you remove it, it's recommended that you replace the inserts with a brand new one for when you insert it back in again. So this is really only done when you have these hygiene visits. So I've seen hygiene visits as normal as like once a year. I've seen it at, like 18 months if the patient's pretty pristine with their hygiene. And I've seen it as soon as 6 months based on patient maybe just not being compliant, or maybe not really even having the dexterity to properly clean under the prosthesis, because that happens as well. And so the one thing I want to point out, and I'm trying to be mindful of our time, is, and this is for all the clinicians out there, the one thing we need to start looking at is like how we're treating our patients now, being cognizant of how old they are, and then where they're going to be in 15, 20 years. And the reason I bring this up is because I had a doctor that I worked with in my lab days with a patient 15 years ago. And Mr. Jones, at the time, he was about 75 years old. Amazing prosthesis, amazing team, amazing surgeon. The lab, that I ran was great. Mr. Jones is now in a nursing home and he's 90. And his health isn't great and he can't take care of himself. And we have to rely on the people in that nursing home to take care of his prosthesis. And so now Mr. Jones is having issues with his implants because he's getting peri-implantitis, peri-implant mucositis. He's not able to clean it. The caregivers aren't really prepared to clean it properly. And so this is something to really think about, especially when it comes to locator fix, because now if I have a patient who's 75 years old, I'd rather put them into locator fixed instead of screw retained. Why? Is because once that patient is 90 and they end up in the same situation that Mr. Jones is in right now, we can convert him or her to a locator removable case. We can put the teeth exactly where the teeth need to go, but now the caregivers can take the prosthesis out and clean it. And we can maintain those implants and the hygiene and the health, the oral health of that patient. So that's something to think about as we're treating all these patients, is where they're going to be in the future and how we're contributing to their, towards their end of life and what that looks like in terms of their oral health. So a couple quick things is, one of the things that you can use locator fix for is a bailout. So if you have a current screw retained prosthesis and you lose an implant, you can replace the implant, put a locator on it, pick it up directly with the prosthesis and not have to redo the whole entire prosthesis again. And this is something that we see, especially with delayed failures out there with these screw retained cases, is we see the peri-implantitis, peri-implant mucositis, we see delayed failures of implants and have to redo the whole case again because it was designed on those certain implants. So I mentioned that you need a minimum of 4 implants. I never said that they had to be all locator fixed. So this is a nice bailout for those types of cases. We have it set up to where it makes it easier for clinicians. So we're having these component storage boxes. We have this for locator removable as well as locator fixed. For those who follow Dr. Christensen, so Dr. Christensen is most of you know, if you follow me, he's not a big fan on screw retain restorations, but he is a fan of locator fixed is because it's easy, accessible to remove, and he's more focused on the hygiene and cleansability of the patient. So he's written a couple clinician reports on locator fixed, and then this is something that we can get out to you. You just email us and let us know. But the prosthetic and lab procedure manual we can share with you, as well as with your staff, as well as we have a white paper that was done by Dr. Michael Shear, our Chief Clinical Officer, and Eric Kukuchka, who's a denturist, and talking about all the different types of materials that they tested, not only materials of the prosthesis, but the materials of the luting materials for the componentry in those various materials. So as I conclude, I just want to point out, Zest is really big on helping to support your practices. So always feel free to go on our website. If you go in the chat box below, you can actually get customer service. You can get them, just chat. You can actually have a virtual call with them, as well as our technical team. Just to let you know, our technical team, 85% of the problem calls that they get, it's on somebody else's abutment. It's not even Zest locator. So something to think about in terms of the disruption that you're going to see out there when you're talking about genuine Zest locator parts. It's, take it from my technical team. They're taking care of everybody else's issues out there. And finally, because Amy will kill me if I didn't say this, we are doing a ton of education for clinicians like yourself. Obviously, it's great to do this webinar with in webinar series with Leixir, but we also have our Global Education Center in Las Vegas, where we have our Zest Mastership. So this is something where I would heavily recommend you taking. That's 39 credits. It's a fantastic opportunity that we have, and this is our facility in Las Vegas. And we can fit anywhere from 40 to 50 people. We have a full operatory, and we're doing a ton of live patient procedures, during our mastership. So I've never met a dentist who was disappointed after they've became a Zest master. So with that said, I just want to point out, don't forget, we have the third part of our series, which is coming up in 3 weeks with Karen. So you can use that QR code to register if you're not already registered. And she's going to be talking about digital workflows. So we're going to take it even deeper into the various record taking, the workflows as it relates to full arch therapy, both removable and fixed. And I just want to make sure I give this, because I always forget the slide, but this is your QR code for your CE credit for this evening. So please take a picture of that. And I'm going to pause here on this slide so everybody can kind of take their picture, but I still see we have a series of different questions. So I'm going to let Alyssa ask them just to make sure I'm not speaking out of turn on any of these.
I've been keeping track. So people want to know more about the education. So I know you mentioned, Todd, they can go to your website, or where's the best place for them to check out upcoming courses?
Yeah, so you can go on our website and you'll find education really quick.
I will attest. I mean, we love working with Zest because the education is always top notch. So as Todd mentioned, you will not be disappointed. There was another question: is locator fixed limited to fully edentulous cases? I can imagine you can use this idea for partial edentulous case or long span or short span bridges.
So great question, Dr. Ip. I'm reading it right now. So currently right now, locator fix is set up for fully edentulous. Now, if you have patients that may have some distal teeth intact, but you still have 4 implants, cross-arch stabilization, you could obviously do some type of combination case with it, as you could with screw retain. I do have some surgical prosthodontists that treat cancer patients, and they have done a lot of things with, they do like like just jaw in a day and nose in a day and ear in a, like face in a day. They're taking, like fibula grafts and scapula grafts, and they're using various implants, using locator and using locator fixed and quadrants and things that just aren't really indicated for what we're FDA cleared for, but they're doing everything they possibly can for these patients. So I share that because I look at that as there's hope for things that we can kind of fall back on and maybe look in the future about how can we expand this locator fixed solution to other applications for patients, whether it's these cancer patients that just, we're pretty much doing everything we possibly can, or for your patient that maybe like in the future, it is a quadrant, but at this time it's currently 4 implants minimum cross arch stabilization. Yeah.
Excellent. Thank you, Todd. I don't see any additional questions coming in.
All right.
I know that Todd, we shared all of our email addresses, so definitely available for follow-up questions. I know Todd referenced a lot, having the right laboratory partner, which is why we're here presenting with Zest. So certainly any follow-up questions or questions around specific cases, Karen is a great resource here at Leixir at the lab.
Yeah. Thank you very much for having us. It's been great.
Yeah,
Look forward to seeing everybody in a couple of weeks.
Awesome. Thanks, everyone. Have a great rest of your night.
Have a good night.
Thank you.
Bye.